everyone. I want to talk about fibromyalgia. Fibromyalgia. This is a chronic, widespread musculoskeletal pain. It occurs in women mostly between ages 20 and 60 years old, formerly known as fibrositis or fibromyositis. 80 to 90% of the affected people will be in their middle age and they will be women. It occurs in both children and adults. The clinical features are widespread musculoskeletal pain, fatigue, sleep disturbance. As a matter of fact, the affected individual will tell you, I have no unrefreshed sleep. Cognitive impairment. This might be the reason why some of them will be in the same unit or the same department with people with dementia because of the cognitive impairment. Psychiatric disorders. As a matter of fact, we refer some of them to psychiatrists. Decreased non-REM sleep stage 4. The reason why they won't have refreshed sleep. Constant aching and paresthesia. Axial pain. Waxing and waning coughs. And it's going to occur bilaterally. There's possibility of headache and bowel irritability. All these symptoms, I'm not saying all of them must occur before the diagnosis could be made, but some of them must be present. And it must be there for at least 3 months. At least 3 months before the diagnosis could be made. On physical examination, we're going to check the joint swellings, but you're not going to find any. So no joint swelling. You check for signs of inflammation, you're not going to find any. So no inflammation signs. There will be 18 tender points, and they are lateral border of sternum, sternocleidomastoid, posterior neck, trapezius, rhomboids, sacroiliac joints, lateral thigh, posterior knee, and medial knee. If you count all those different points, that will be 9, and bilaterally that will make it 18 because it is bilateral. So 18 tender points. To make the diagnosis, we need at least 11 over 18. Then the diagnosis could be made. The laboratory investigations that we're going to do will involve acute phase reactants like erythrocyte sedimentation rate and C-reactive protein with complete blood count, thyroid function test, and creatinine kinase. You want to rule out any problem with the heart because we're talking about pain, and particularly in someone that is 50 years and above. So you have your troponins and CKMB. But in all this, you are not going to pick any pathology because every of these results will come back normal. Let me repeat. All these investigations will come back normal. So normal ESR, normal CRP, complete blood count, all within normal range, normal thyroid function test, normal creatinine kinase, normal troponins, normal CKMB. How do we treat this disturbing condition? Well, the truth is it is very difficult to treat. That is not to scare away the affected individuals. We are going to involve other people from other departments, so it is multidisciplinary approach. And physician, particularly the family physician treating the family, will be involved. Needless to say that nurses will be involved. Psychotherapists, occupational therapists, because some may have to change their occupation, psychiatrists, mentioned that just a while ago, and physiotherapists will be involved. The affected individual should be educated on the nature of the disease so that they will have their mind prepared for the long haul. Exercise will be encouraged and sleep hygiene will be taught. We are going to address any associated comorbidities, and we can start with monotherapy, and that will involve amitriptyline. As a matter of fact, in the olden days, it's only amitriptyline. Now, we can combine selective serotonin reuptake inhibitors like fluoxetine and amitriptyline, or duloxetine in the morning and pregabalin at evening time. Some might go for vancomycin in the morning and pregabalin or milnacipran at the evening time. Others will use tramadol, acetaminophen, and non-steroidal anti-inflammatory drugs like ibuprofen or naproxen. Cyclobenzaprine, low dose, or naltrexone, memantine, or seroquel could all be used. But we need to consider the side effects of all these different medications and not indulging in polypharmacy. However, consult should be sent to rheumatologist. And you can ask me why that. To confirm the diagnosis and to review the treatment given. Consult may be sent to psychiatrists if we pick mood changes. It would be wise to refer to pain clinic if we are not winning. To those who could take it, I'm not advocating that should be done. Acupuncture or yoga is not out of place. There is future modality, and that is transcranial direct current stimulation. We hope that will be very helpful in the future. And transcutaneous electrical nerve stimulation could be done as well. What are the possible differential diagnoses here? This might be systemic inflammatory arthropathies or spondylitis, systemic autoimmune disorders, polymyalgia rheumatica, myositis, inflammatory myopathy, neuropathies of different causes, hypothyroidism, rheumatoid arthritis, and hyperparathyroidism. So when we are thinking that the diagnosis is fibromyalgia, we need to do a lot. Then when that diagnosis is made, we know what to do. And when we're not winning, we know who to refer to. So it's a long haul, and we need to prepare the mind of the affected woman or young lady beforehand so that there will be cooperation and we can have success. Kindly subscribe to my channel and you get these publications immediately they are released. Thank you.